So it's a real pleasure to introduce our next speaker, Dr. Suzanne Boyle, who'll be talking about the nephrology workforce. So Dr. Boyle is an associate professor of medicine and nephrology fellowship program director at the Lewis Katz School of Medicine at Temple University in Philadelphia. Dr. Boyle was the 2021 recipient of the William and Sandra Bennett Clinical Educator Grant from ASN's Kidney Cure Grant program. She developed and validated a formative tool to assess clinical reasoning skills in nephrology fellows. She's a member of the ASN Workforce and Training Committee and has served as chair of the ASN Data Subcommittee since 2022. In this role, she's the one who helps develop and analyze the annual fellow survey, which I'm sure I've heard of. It provides key data and perspectives on nephrology training and the job market for new nephrology graduates. She's published a lot on various aspects of the workforce, such as nursing shortage, subspecialty trends, and pregnancy and family planning policies and fellowship programs. It's a real pleasure to have her here today. Thanks for joining us today, Dr. Boyle.
Thank you so much for having me. It's such a pleasure to be here. So the title of my talk is there a workforce shortage? And if so, what can we do about it? I have no relevant financial disclosures. So this is essentially a talk about supply and demand. You may be relieved to know I will not show any additional supply and demand curves because I am a nephrologist, not an economist, and these give me nightmares about economics in college. But what I will do is discuss what the supply of nephrologists is currently, what the demand for nephrologists is, how we can influence the supply, and how we can influence the demand. But before we start that, I think it's important to acknowledge why we're having this discussion. And we're having this discussion because many sources project that we will have a shortage of nephrologists in the United States. One of those organizations that projects this is the Health Services and Resources Administration, or HRSA, which is an agency within HHS. And this is data from a model simulation that they performed to look at a metric called physician adequacy for the year 2035. And what this adequacy metric is essentially the ratio of the supply of physicians to the demand of physicians. So if you're over 100% in a given specialty, that means that you have more than you need. And if you're less than 100%, you don't have enough. This model, very importantly, does not account for how advanced practice providers, for example, may help with narrowing the gaps that we have to provide this care. But what you can see is that of all of these specialties, nephrology is among the three lowest adequacy percentages for 2035, along with ophthalmology and thoracic surgery. So let's jump into supply. So our workforce supply is simply the incoming workforce and the departing workforce. So even though that we have a shortage, we actually have seen the number of nephrologists in the US, the absolute number of nephrologists increase over time. And that has been more than 50% between 2008 and 2020. Now, you may also be surprised to know, because we spend a lot of time talking about how we have failed to do well in the match, and usually we only fill 60 to 70% of positions offered in the fellowship match, that by the start of a new academic year, we usually have filled all the spots post-match. Who fills these spots? We don't know exactly, but they're probably what we call hospitals to nephrologist converts, those who have unmatched in other specialties, or something called exceptionally qualified candidates, which I will discuss a little bit more later. So in addition to filling nearly 100% of our spots, at least after the match is done, we've also seen the number of nephrology positions increase over the last 15 years by more than 100. So we are training more nephrologists today than we were 15 years ago. Who are the nephrologists that we're training? So this is data from the ASN's annual fellow survey. And if you look at the adult fellows, the majority of them are international medical graduates. And this mirrors what is the case in the broader population of practicing nephrologists. Most nephrologists are men, and most nephrology trainees, at least adult trainees, or at least, excuse me, a third of them are on visas, and 25% of those are on J1 visas. So oftentimes people postulate that we may be losing some of our new nephrology graduates to other specialties, for example, like hospital medicine. But that doesn't seem to be the case. So on our fellow survey, we see that by far and away, the overwhelming majority of graduates do stay in clinical nephrology for their first job after graduation. So let's talk about the outgoing workforce. And the outgoing workforce, you could think about if those who are retiring from the workforce and those who may leave to pursue another specialty, perhaps leave medicine entirely. So retirement. You know, I've probably heard of the silver tsunami, which is the aging of the baby boomers. And there are a lot of baby boomers in our nephrology workforce. And you can see that here. These are women, these are men, and the circles represent people over 65. So over the next 5 to 10 years, we are likely to see a large chunk of our workforce retire. Also, we wonder about who may leave nephrology for other specialties, including hospital medicine, which I mentioned, because people postulate because it's difficult sometimes to secure J1 waiver positions in nephrology, that hospital medicine or primary care may be attractive. The other question is, for those who subspecialize in nephrology, and particularly those who are interested in nephrology critical care, which has increased in popularity over the last several years, do those fellows remain in nephrology, or do they mostly practice the critical care specialty? Now, this is a really small proportion of our total nephrology graduates, but still, it's something to consider in terms of retention of our nephrology workforce. Let's now talk about demand. So, nephrologists, where are they? This slide is courtesy of Curtis Pavere, who is ASN's Director of Data Science. It uses data from CMS to show where most nephrologists in the US are practicing. The divisions you see here geographically are counties. What you can see is in green, most nephrologists tend to cluster around metro areas, large metro areas, which is not a surprise. Now, where is the CKD? So this data is from the CDC. These are Medicare beneficiaries who carry a CKD diagnosis over the age of 65. This data is from 2021. And you can see here in the darker pink is a higher density of CKD, that these do reach beyond the metro areas where most of the nephrologists are. And when we superimpose these two maps, we can postulate how supply meets demand. So where supply and demand are met adequately, that would be here in the blue. So you see that's sort of largely in the Northeast, Florida, Southern California. And then where we aren't meeting demand are like the pink and the purple colors, where you can see, you know, them sort of spattered throughout the map here. Now, back to HRSA data, using this metric of percent adequacy, which is again the supply over the demand of nephrologists per state. The darker colors indicate states who have a strong percentage adequacy, close to 100% if they're very dark. So this is important because some states that have a decent percent adequacy, they may have pockets of underserved regions where they do not have enough nephrologists to meet the socially vulnerable populations there. This maldistribution of nephrologists can be seen in these maps here. So if you look on the left, this is primary care centers that are in health professional shortage areas. So the darkest color is where there's the highest amount of shortage for primary care. So you can also then go look and see what the distribution of the comorbidity of stroke is across some of these areas. And so you see the highest levels of health professional shortages, in these dark green. There's some, in Texas. This looks like, here in parts of the Midwest, Colorado, et cetera. And then you map it over here and you can see that often these are the same places that have very high incidence of stroke. And interestingly, where we don't have health professional shortages, which is in the Northeast, this tends to be where there is less comorbid stroke. So there's a maldistribution of nephrologists. So how can we influence the supply of nephrologists to meet the demand? So I think there are three broad strategies that I will go over. One is what I like to call make nephrology attractive again. We'll talk about ways to reduce entry barriers for international medical graduates because they are the lion's share of our workforce in nephrology. And then finally, reducing barriers to interstate licensure to increase nephrologist mobility. So let's make nephrology attractive again. So I like to show this slide for context. Now, this is just my hypothesis, but I believe that our challenges with the nephrology match have a lot to do with the rise of hospital medicine and the potential brain drain to hospital medicine because of things like lifestyle, maybe higher starting salary, and the ease of entry, that you don't have to do any additional training. So I think this picture says it all. So in 2010, we had 1.5 applicants for every position offered in the nephrology match. And over the next 15 years, that declined to a ratio of approximately 0.6 applicants per spot offered. Around the same time, you see that the hospital lists began to rise. And I don't think that these two patterns are a coincidence. I think that one is related to the other potentially. So to make nephrology attractive again, we need to target certain populations. And on the annual fellow survey, we always ask, when did you decide to be a nephrologist? And pretty consistently, people say that they decided between PGY2 and PGY3. So this is a really great target population for making nephrology attractive. And there are a lot of programs that have been focused on these early learners to try to get them excited about nephrology. And a lot of them leverage social media, create mentorship opportunities across geographic barriers. One in particular, the ASN Kidney Stars, which has a curated experience for medical students, residents, and graduate students at ASN Kidney Week. Actually, about nearly 20% of respondents every year on our fellows survey indicate they participated in this program. And while these programs certainly haven't closed the popularity gap that we see in nephrology, I would argue that we don't know the counterfactual and that without these types of programs, we may have seen that we have lower quality applicants or fewer applicants into nephrology. The other thing to know is that early career nephrologists really value lifestyle and value lifestyle really more than compensation pretty consistently on our annual fellows survey. Compensation lags behind weekend call frequency, overnight frequency, desired location, vacation time. And so I think it's really important as we try to sustain our profession that employers meet new early career nephrologists where they are and try to be creative about creating positions that value what they value in lifestyle. A little bit more about compensation. So what you see here on the left-hand side, this was the average the median starting salary for international medical graduates in 2024. And below that is the median educational debt reported by international medical graduates on the survey. On the right-hand side, it's the US grads median initial salary and the US grads median educational debt. And you see that US grads have more median educational debt than they do their initial salary. The discrepancy between the IMG starting salary and the USMG starting salary may be secondary to where IMGs tend to practice after they leave their fellowships. A lot may go to places where there is high demand and perhaps higher salaries as a consequence. But overall, over the last several years, we've seen an increase in both USMG and IMG starting salaries, which are beyond inflation. So we wanted to drill down a little bit more on compensation with our group on the ASN Data Subcommittee. And Raja Roslin of Duke University created some questions to try to do that. And so she asked nephrology applicants how they perceive nephrology compensation compared to other specialties. And the majority said that they thought it was below average, which is actually a misconception, that nephrologists on whole earn less than other subspecialties. We also asked how important future earnings were in the decision for those fellows to become nephrologists. And interestingly, it really was not that important to the majority. 70% said slightly, not at all important, or neutral. And among those who had debt, we asked how influential debt was in the decision to become a nephrologist. And again, it really wasn't very influential for most applicants. Among those who did have debt, only 38% reported enrollment in loan forgiveness programs, the most popular one being the Federal Service Public Loan Forgiveness Program. So what we take from this, which I guess is a good thing, that people really love nephrology and they want to do it and they don't care so much about the money. But the elephant in the room is that we did not survey people who didn't choose our specialty. So I think that it's important that we increase transparency about all revenue streams and earning potential in nephrology, including joint ventures and partnerships, and looking at long-term earning rather than short-term earnings. Also leveraging resources like Verify, which is an organization that will allow ASN members, for example, to have access to physician productivity and compensation. And being a contributor to Verify will allow us to get more accurate data on nephrologist salaries. And further, I think enhancing awareness of loan forgiveness programs is really important. This was terribly underleveraged among those of our fellows who carry debt. And importantly, a lot of loan forgiveness programs come with a service component, which could help get nephrologists to places in the country where we need them the most. All right, so let's talk about reducing barriers for international medical graduates. So I don't think it comes as a surprise to anyone here that the path to practicing in the United States for an international medical graduate is not a short one. They have to go through many steps, the first of which is ECFMG certification. Then they go through traditional GME training, applied to an IM residency, and only 60% are successful in the IM match. So often they have to go back and try again if they really want to do this. Then after they successfully match, they have to obtain a visa, either a J1 or an H1B visa. They have to complete residency, step 3, and then complete their nephrology fellowship. And if they're on a J1 visa, which is an exchange visitor visa, in order to waive the requirement to go back to their home country for 2 years and stay in the United States in practice, they have to give 3 years of service in an underserved area through programs like the Conrad 30, the Appalachian Regional Commission, or the Delta Regional Authority. And it's often difficult to find these positions and find them in nephrology because a lot of times states will reserve them for those going into primary care. And after this has been done, they can apply for an unrestricted license, sit for the boards. So there's all these steps before they can practice independently. So since 2019, on the fellow survey, we have been asking fellows if they have done a residency in the United States prior to their fellowship. And what we've seen is over that period of time, those reporting not doing an ACGME accredited IM residency program has increased. And based on the survey, approximately 30 graduates per year, but that's an underestimate because the survey is only 40 to 50% response rate. So I think this is much more than 30 graduates a year. These graduates are what we call these graduates, these trainees, are what we call exceptionally qualified. And I mentioned them earlier in the presentation. And essentially what that means, and I'll define it in a second, is that they're doing a non-traditional sort of flipped approach to training. They do their fellowship first, then they can do an accredited IM residency, and then they can sit for the IM boards and subsequently the nephrology boards. And if they pass, they can practice nephrology. What does it mean to be exceptionally qualified? The definition of this is a bit nebulous. And what I'm showing you here is from the core program requirements for the ACGME, who defines exceptionally qualified international graduates as those who have completed a residency in the core specialty, so in this case, internal medicine, outside the continental US that was not accredited by the ACGME, the American Osteopathic Association, ACGME International, or Canadian programs, and they have to demonstrate clinical excellence in comparison to peers in domains such as clinical research, scholarship, and leadership. To take an exceptionally qualified candidate, you have to have your graduate medical education committee at your institution approve that person and that they are exceptionally qualified. And then that person needs to undergo a little bit more of rigorous evaluation through their training and meet with the clinical competency committee of the fellowship program more frequently than they otherwise would have to twice a year. So it's not clearly defined what exceptionally qualified is. It's really at the discretion of the hiring institution to make that call for themselves. So if you are exceptionally qualified and you're doing a fellowship before residency, how do you get to board certification in nephrology? And one way I mentioned already is to do the fellowship, then you apply for residency, and then you become IM and nephrology board eligible. That's what I call the flipped fellow. There is another way to do it that's called ABIM Pathway A. You do the fellowship, and then if you're hired at an accredited medical school as a faculty member for 3 or more years at the assistant professor level, you may be eligible to be both IM and take the nephrology boards as well. And soon, there may be another pathway. That's the ABIM pilot program, where you do an ACGM accredited fellowship, but do not have to do this intermediate step. And there will be a more streamlined pathway to just becoming IM nephrology board eligible. So this ABIM pilot pathway, if you're interested for the exceptionally qualified candidate, you can read about this more with the QR code. It's not active yet, but it recognizes that there's more than 4,000, the ABIM estimates, trainees in the United States, or actually physicians, they're not trainees anymore, but physicians who fell under the exceptionally qualified clause, and they want to get them understand this population more and see if we can use this population to fill healthcare shortages and collect data too as part of the pilot program. So it's not available yet, but it should be available soon. Now, another alternate pathway to state licensure that's very disruptive is one that actually totally eliminates the need for a residency in the United States. The first state to pass such an alternate pathway is Tennessee. That was early in 2023, and this is an editorial that was written in the New England Journal about this alternate pathway. And I'll just sort of tell you the main differences between a traditional pathway to independent practice in the United States and one that would be under this alternate pathway for international medical graduates. And again, this is specific to the Tennessee statute. But, under the normal pathway, you would not necessarily need to complete postgraduate training or have practiced in your home country. You'd come here and do a residency and start at square one. But if you're an IMG who has practiced at least for 3 of the last 5 years or done postgraduate training abroad, you would be eligible potentially for this pathway. Most of people who go through the current residency training fellowship pathway, a lot of them are on the J1 visa. You would be on an H1B visa with this alternate pathway, so that's an employee-sponsored visa. You would receive something called a provisional license, which is a little different from a trainee license because you can practice under supervision, but outside the context of a ACGME accredited residency or fellowship program. And salaries are not standardized with this new alternate pathway. They would be at the hospital's discretion. Also, and ultimately, the specialty that you practice is really also at the hospital's discretion. This, for example, in Tennessee, has been used to recruit ENTs. It does not follow, obviously, the typical rules that you would need to have done a fellowship, perhaps, to practice in nephrology. If there was a nephrologist need and you had credentials, you could take this alternate pathway to potentially practice. Now, it's important to know that licensure does not equal certification. So currently, there is no pathway to board certification for people that go this alternate route. Since 2023, 11 states have passed legislation for an alternate pathway, and 23 have proposed or have pending legislation. If you're interested in seeing an updated version of this map, there is a QR code there. And these three entities, the Federation of State Medical Boards, InThealth, and the Accreditation Council for Graduate Medical Education, have come together to create some recommendations for state medical boards, because it's really the state medical board's job to see that these new licensed doctors receive their licenses in practice. They want to make sure that there's some guidance across the board, across states. If you'd like to see the 9 recommendations that were issued in February 2025, you can see that with the QR code here. So what does alternate licensure mean for nephrology? Well, I think there's lots of questions we don't know the answers to, but some that come to mind are, will less IMGs become nephrologists in favor of this shorter pathway? Will IMGs practice nephrology without board eligibility through the pathway within the state that is sponsoring them? We do not know. And finally, reducing barriers to interstate licensure to improve supply. So any state that's not in gray here participates in the Interstate Licensure Compact, which means that if you are primarily licensed in a participating state, you can get a license in the other participating states. And this is helpful because it will increase physician mobility. It also provides the opportunity to use telehealth to perhaps deliver more highly specialized care in glomerular disease to areas, for example, that don't have access to this. And finally, briefly, how can we influence the demand for nephrologists? So the first thing that I'll talk about is the smart use of advanced practice providers, or APPs. APPs are nurse practitioners and physician's assistants. And you can see from this graph here, based on data from the NKF Council of Advanced Practice Provider Survey, that APPs practice in lots of different clinical settings in nephrology. Most commonly in hemodialysis and in the office setting, but really in all of them. And if you look at the literature, there's a lot of data to support how APPs, when used smartly, really add value. Here are 2 examples. This is a paper that was a Canadian group who did a propensity matching of a nephrology nurse practitioner with primary care alone, and propensity score matching of a nurse practitioner's practice with a nephrologist. And when comparing the nephrologist NP to primary care, there were better long-term outcomes. There were less likely to be prescribed NSAIDs, more likely to prescribe RAS inhibition, and the same was actually true when compared to nephrologists. NP nephrologists did better with RAS prescription than nephrology colleagues, and there was no difference in outcomes between the 2 groups. And this second paper looked at creative ways to use APPs at the University of Chicago on their dialysis service that really allowed the service versus education burden to be lightened for fellow trainees and really enhance the care that the patients were receiving. A couple of other things, using AI-driven risk-based triage for CKD referral. I think we all can relate to that feeling when you're sitting in clinic and you have an 89-year-old woman that you're seeing with a creatinine of 0.9, and she's lovely, but you're just thinking, whose spot is she taking? A patient I really need to see that couldn't get in with me. And that's why risk-based triage is important, and this can be accelerated using AI. This is not a risk-based or an AI-driven algorithm. This is from Dr. Tangri's group in Manitoba, but it shows how using his kidney risk failure equation and other data points can help prioritize certain high-risk patients for referral. And along that vein, using EMR integrated workflows for high-risk patients, identifying who those patients are, and then providing decision support for management so that we can get those patients onto combination goal-directed medical therapy for kidney health preservation. And this has the potential to significantly reduce the global burden of CKD. While we don't have actual, I think, models, to my knowledge, of how much this may reduce the global burden of CKD and dialysis over what time frame, with broad-scaled implementation, this definitely has the potential to be done and will decrease the demand for nephrologists. So with that, thank you very much for your time. I want to thank Curtis Pavera, who is the Director of Data Science at the ASN, for all of his work that he contributed to this presentation, and the rest of my colleagues on the ASN Data Subcommittee. Thank you so much.
And so I think one thing we hear from a lot of fellows, because this topic is kind of very near and dear to our heart, is that the nephrology they're exposed to during their residency is very different than the nephrology they're exposed to later. So they get a lot of like acid base, inpatient fluid and electrolyte, kind of like the cool physiologic problems, where they see, whereas they see kind of outpatient nephrology is like round on dialysis 4 times a week, very basic CKD care. Kind of how does that play into people's willingness to go into kind of general nephrology versus wanting to subspecialize in critical care or transplant or something else, or skipping nephrology altogether?
Well, I think that's a great point. And I think that there is evidence that at the institutional level, you really have to have sort of grassroots approaches to getting people into nephrology and having sort of creative electives, outpatient electives, where they go to the dialysis unit, they see the peritoneal dialysis patients, the people that aren't ending up in the emergency room, that actually can make a real difference. That sometimes having a primary nephrology service where instead of a hospitalist, you have a nephrologist, for example, so that you can learn sort of directly from the nephrologist. It's not an elective either, so the residents get to take more ownership, and making sure that the patients who are on that service may not just be the people that miss dialysis, that they see other cool things. So I think at the institutional level, those types of efforts are really important.
Thanks so much. Unfortunately, we have to move. There are a lot of questions in the chat. We'll have to move on for now, but if you have a second, if you don't mind, maybe you can address some of them in the chat.
Absolutely. Thank you so much.